I am going to introduce with great pleasure the next speaker, and then I also have to take a plane, so thank you all for this wonderful meeting. So it's my pleasure to introduce my colleague, Dr. Victor Ferrari, who is a fellow of the ACC, of the FSCMR, of the AHA, and of the American Society of Echo. He's a professor of medicine and radiology at the University of Pennsylvania. And he is also the chair of the Penn Cardiovascular Imaging Council and past chair of the Imaging Council of the ACC. And Dr. Ferrari is going to give you an update in cardiac imaging with a special attention in women.
Good morning. Thank you very much again for the nice introduction, Marielle. And without further ado, I think we'll focus on our topics today in imaging with women. I want to make an apology. First of all, I did not cover cardio-obstetrics today. There just wasn't enough time, but clearly that's an important topic. Mainly we focus on echo and also CMR with respect to potential myocarditis in these patients, but it's a topic I don't have time to talk about today. I'd also like to thank Jennifer Mirez for this slide, and given the theme of our conference for medicine and society, I want to remind everyone that we really need to integrate cultural competency and think about implicit perceptions when we're talking to our patients. And this concept of patient as partner, helping with decision making and also being an important part of the discussion with regard to care is critical. In general, we followed paternalistic approaches in the past, but we really want to follow patient-centered approaches as we move forward, and finally the patient as partner approach. Interestingly, 80% of a population's well-being, if Rochelle is still here, that is the quality of life factors, social determinants of health, and actions in healthcare, and indeed also their happiness, account collectively for about 20% of society's well-being. And I think we have to also keep that in mind. A healthier population is a happier and more productive population in general. And I think everyone deserves to have that opportunity to be healthy and happy. There are some, with regard to updates in imaging in general, there are new landscapes and changing participants in the healthcare system. We're moving from a fee-for-service model in the States, at least that's what's been reported. It's a slower march than usual. And we're moving from fee-for-service to quality metrics. Obviously that may hurt and is causing some pain and angst along the way. We're moving toward higher value rather than higher volume studies. So again, duplicative studies or the ability to order studies repetitively or in tandem and stacking of studies, stacking of modalities is not going to be permitted. It's also obviously wasteful for resource-constrained countries. And we're moving beyond process measurement to outcomes and results. And obviously, this is where the rubber hits the road. Dr. Galati has introduced a number of these topics, so I'll move quickly through this. But just in terms of imaging and men versus women, in general, women have smaller hearts than men. That means that chest geometry and breast size may complicate optimal imaging with echo, but this is usually not a problem. Generally, we can move beyond those constraints. However, thinner myocardial walls create challenges for the assessment of non-transmural ischemia. I showed you yesterday an MRI perfusion study demonstrating subendocardial ischemia. That's more challenging with PET or with SPECT if the wall is even thinner in terms of detecting true ischemia. And also, smaller infarcts may be missed on SPECT or PET with a thinner wall and lower signal intensities with nuclear imaging approaches. And in general, women have smaller coronaries than men, which complicates the accurate assessment of the distal coronary arteries and on CT, and also the FFR CT calculations. So all of these things need to be kept in mind, in front of mind for treatment of patients with with coronary disease. Now, depending on the chest configuration and breast size, women can absorb up to 30% greater radiation than men. And therefore, when possible, non-ionizing radiation tests are preferred. And this is especially important in younger women whose lifetime radiation exposure may be relevant regarding future cancer risks. I'll also direct you to two papers that we wrote last year regarding the impact of radiation on patients and also operators in cath labs or in EP labs. And studies are getting longer and more complex lately, and the operators need to be more cognizant of this as well, Stefan. In terms of quantitative cardiac imaging, this is where some differences are important to recognize and may not be in front of mind for us when we're performing these studies. Echo relies on geometric assumptions as to cardiac shape, and it assumes a bullet-shaped left ventricle. And while that's fine for normal hearts, generally we don't treat patients with heart disease that have normal hearts or study this in great detail from a research standpoint. This introduces errors in the measurements in diseased hearts of mass and volume and ejection fraction. And off-axis imaging leads to errors in calculation. This is particularly important in deformed hearts, such as those post-MI that have an aneurysm. Now, tomographic imaging, such as MR and CT, eliminates these assumptions and the obliquity errors, and since an entire 3D volume is acquired. And while 3D echo is available for imaging, for volume and ejection fractions, it's not quite ready for prime time, unfortunately, and except for certain TEE applications. But for transthoracic echo, it really hasn't hit its mark just yet. Now, Dr. Gulati talked about symptoms in women. I'm not going to belabor this, but we always have to remember that symptoms can be atypical in women, and it limits, there are frequently limitations in patients and women exercising on treadmills to hit their target heart rates. Obviously, advancing age, orthopedic problems, and conditioning issues can reduce the sensitivity and specificity of stress testing. And we already know that there are low sensitivities for women because of EKG abnormalities that are different from men, reducing the specificity for exercise EKG down to about 60%. Stress echo has only about an 80% specificity for coronary disease, and stress spec slightly higher at 81%. In terms of disease prevalence, there is a much greater incidence of non-obstructive coronary disease in women, and therefore a higher risk of plaque rupture in these 20 to 30% lesions. So while angina may not be the most prevalent symptom, acute MIs are in greater frequency with these smaller lesions. Now, we obviously need to listen to our female patients more carefully. I want to read these statements that I think are really important, and I think they really encapsulate the problem. Even when accounting for sex differences in risk factor prevalence, a smaller body size, higher bleeding risk, and other factors, women have decidedly worse outcomes after coronary revascularization, particularly in the near term. So just going in and fixing the plumbing isn't going to be the answer. Also, the lack of symptom-driven care for women that have demonstrable ischemia is a major contributor to their worsening ischemic heart disease outcomes. INOCA and MINOCA are really important in reducing women's favorable outcomes with ischemic heart disease. And interestingly, 1 year after the index evaluation of patients, of women with symptoms, nearly 40% of symptomatic patients have persistent or worsening symptoms. So clearly our current approaches leave large gaps in the understanding of coronary disease in women. Now, are gender differences important in stable ischemic heart disease? They certainly are. If we look at this data from the extent of coronary artery disease by coronary CTA, we can see that women on the left, while they may have less incidence of non-obstructive coronary disease than men in general, if you look at the outcomes and the survival for three-vessel disease or left main disease, it's dramatically lower. And I think this has to do with the fact that women escape detection early in their course and often have more severe disease or more critical disease after a time duration. And here's a good example of that. We have a QCA stenosis of only about 36% on the left-hand image. That would be obviously non-severe, non-critical disease, but look at the coronary CTA that is associated with that lesion. It's complex. There is calcium there, there is soft plaque. This is a lesion that could potentially rupture and is at risk for disease. We also need better tools at assessing which lesion is most vulnerable and which is the most active, and whether we're shutting off inflammation satisfactorily, not just a serum CRP, but maybe even a local imaging tool to show that we're really reducing that residual risk that statins and anti-inflammatory properties of ACE inhibitors provide. To bring you to the PROMISE trial, this was a study that looked at coronary CTA versus functional imaging. And these were about 10,000 patients that had suspected CAD and intermediate coronary disease risk. The composite primary endpoint used was death, MI, unstable angina, hospitalization, or a major procedural complication. The study had 53% women, and 88% had chest pain or dyspnea on exertion. There were also some secondary endpoints, which I won't go into at the moment, but interestingly, there was no difference in the outcome between coronary CTA approach for diagnosis versus functional testing. And the CCTA group had a greater mean but a lower median radiation exposure, and that was more reflective of the site variation rather than true risk. That is the site where these studies were performed in the across the geography of the trial. And interestingly, more patients underwent revascularization, both PCI and CABG, but that wasn't actually a true trial endpoint. If we look at the outcomes of patients, the anatomical testing and the functional testing showed a comparable outcomes. And this also relates to the following slide, which shows that there is increasing mortality with an increasing number of abnormally perfused regions in women and men by rubidium PET. But here there are definitely differences in gender differences between men and women with regard to outcomes, but interesting, the trends are the same. That is, with more abnormal regions of disease, there are more events. I wanted to remind you that these small infarctions that are detectable with coronary MRI, with cardiac MR, that are the footprint of a subclinical coronary event are important and have an important step on outcomes. In a smaller or thinner wall, smaller heart and thinner wall, we're not going to see these abnormalities on nuclear imaging, and therefore CMR will help pick this up. In a society that has a high prevalence of diabetes, missing subacute infarctions and coronary events can be critical in reducing outcomes. Now, just as an introduction, there are some misconceptions about cardiac MR. It's been criticized as taking too long, can't be performed in ill patients, lacks exercise performance data, there are motion artifacts, and it's limited in terms of prognosis by smaller studies. Just want to show you this image, which is a planar axial MRI using a technique called compressed sensing. That is an ultra-fast MRI technique that is now standard on CMR imaging machines. And what this does is provide nearly isotropic resolution. Now, that means that the pixel size, that is those picture elements that make up every voxel or vox element within the image, are nearly the same size. That is, these are 1 millimeter by 1 millimeter by 1.25 millimeters. The benefit of CT angiography is that it is isotropic. They have sub-millimeter resolution, so 0.6 by 0.6 by 0.6. So you can twist and reconstruct the image any way you'd like and see the image at the same resolution in each view. With cardiac MRI, we're getting closer to this isotropic resolution. This is the closest we've ever been to assessing coronary arteries themselves with CMR, and the resolution for myocardial detection and structural detection is absolutely outstanding. So this is a new era in cardiac MRI. Now, with respect to lacking functional information, that is how far a patient can go and how many METs they can perform, there is now available a stress device that is a treadmill that is MR compatible, can go into the room, and patients can exercise at the bedside using these ultra-fast imaging techniques. We're able to have the patient lie on the table and slip into the scanner, and we can image the heart at heart rate and at target heart rate, and have that image information about, have that prognostic information about their level of exercise performance. Now, I want to present a case to you, and this is of interest to our rheumatologist friend who asked the question earlier. This is a 37-year-old who presents with visual changes, chest pain, and tachycardia, a heart rate to the 120s and 130s. And she was diagnosed with cerebral lupus. The question was, does she have lupus myocarditis because of this inappropriate tachycardia? And very interestingly, on the MRI scan in the upper two panels, on the left-hand side is her baseline image, and on the right-hand side is after treatment. We can see that her myocardial edema, that is inflammation as detected by T2 mapping with MRI, showed a significantly elevated signal of edema within the myocardium. That is inflammation, active and acute inflammation in the myocardium. And interestingly, her stress perfusion MRI study shown in the lower panel shows diffuse subendocardial hypoperfusion. That is, if you look at that dark ring along the internal border, that is the endocardial border, just adjacent to the bright blood pool, you can see that there is subendocardial ischemia. This cannot be well detected with echo, and with SPECT, this would be eluded. It would not be detected with SPECT. PET does a better job than SPECT of detecting it, but sometimes PET can miss mild subendocardial edema, such as, subendocardial hypoperfusion, such as this. Interestingly, after treatment, in the right-hand panels, her myocardial T2 signal came down. That is less edema and resolved. This is in the normal range now. And look at her stress perfusion MRI scan. It's now normal. So she had an acute inflammatory episode with lots of microvascular dysfunction at the time of the inflammation that has resolved with treatment. So detecting these abnormalities instead of just saying this patient just is anxious and has a tachycardia is critically important to her care and also her prognosis. So our overall paradigm for imaging considerations for women in coronary disease can follow this type of rubric. And I'll recommend this paper by Lauren Baldessari and Leslie Shaw as a guidepost for you. Looking at the non-obstructive high-risk plaque in women is critically important. Understanding the extent of disease, its configuration, and whether a woman is at risk or not for coronary artery disease is extremely important. And so identifying those abnormalities, either with coronary calcium scores or likely coronary CT angio in women that are symptomatic and have a risk profile that would require it and that would support it, is important. In the middle, looking at the PET scanning, these are studies of the functional abnormalities, that is microvascular dysfunction, where nuclear imaging and CMR have value. And then finally, recognizing scar, the presence of real scar, or unrecognized myocardial infarction subacute clinical scar is a big factor in detecting disease. I also don't have time to go into MINOCA or INOCA in great detail, except to say that myocardial infarction with non-obstructive coronary artery disease, as well as ischemia with non-obstructive coronary disease, is an important problem in women. And the causes of myocardial infarction with non-obstructive disease, such as coronary plaques or erosions, spontaneous coronary thrombosis or embolism, or missed obstructive coronary disease, and we frequently see that now that we have better coronary CTA and myocardial assessment with CMR. Are important. Obviously, myocarditis, including giant cell myocarditis, which is particularly virulent and damaging to the myocardium, Takotsubo and other hypertrophic cardiomyopathies can be detected and are important. And on the INOCA side, vasospasm and then microvascular dysfunction are two important diagnoses that we can't miss in women. I'll direct you to this paper by Dr. Galati, also improving outcomes for women in STEMI, listening more carefully at the beginning, including more women in trials, and recognizing that we should have more standardized protocols are among the ways to improve outcomes with STEMI. This is a demonstration of a large number of patients with, who have undergone stress CMR, and this demonstrates the value in a group of over 11,000 patients who had stress CMR in terms of the positive and negative predictive value for stress CMR. The event rate with a negative stress test, that is, what's the value of a negative stress test? It's a event rate of less than 1% per year. That is either death, MI, or a combination of both. Whereas a positive stress CMR has an event rate, an annual event rate of nearly 3% for either death or MI, or almost 5% for the combined infarction, MACE. So it's an excellent test for assessing prognosis, either positive or negative. Now, I'll introduce you to two trials that were performed recently. The CE Mark trial, which shows that CMR in blue had a greater area under the curve, or greater predictive capacity for coronary disease than than SPECT imaging, and that was in any type of any severity of coronary disease, 1, 2, or 3 vessel disease. And the MR Inform trial, which compared FFR directed therapy to stress perfusion CMR in terms of accuracy for prediction of coronary disease and also outcome. And we see that the curves are overlapping for CMR versus FFR. So CMR is as good as FFR for detecting ischemia and coronary disease in patients. So Dr. Galati mentioned the WISE trial, which demonstrated that the spectrum of coronary disease extends beyond the epicardium to the microvascular disease, as well as endocardial dysfunction. There's a lower epicardial coronary disease burden in women, but more angina and poorer prognoses. Interestingly, in the PROMISE trial, which was stable ischemic heart disease, women were identified as lower risk, quote unquote, despite having comparable risk factors, and had 2 to 3 times the events with more angina in 1 year post-MI. And future algorithms, I believe, must include functional, anatomical, and physiologic assessments of coronary disease, both endothelial and the microvasculature. And CMR, I believe, is the ideal test for ischemic heart disease in women, and that's my opinion. Coronary calcium scores in women. There was a discussion earlier, a question earlier about risk factors and what do you do with young women that might have symptoms. Unfortunately, coronary calcium scores are not have questionable utility in women between 45 and 64. You can see the percentiles by race. The top white, second Chinese, third black, and fourth Hispanic. Across the races and ethnicities, there is a low incidence of coronary calcium positivity in younger women. So that may mean that coronary CT angio is more informative because it can detect non-calcified plaque as well as small calcifications that might elude coronary calcium scores, and also give us an idea of these 20 to 30% lesions that are mostly fatal. I don't have time to go into great detail about FFR CT, but it's been proposed as a measure of a degree of ischemia. Unfortunately, it's 4 times the cost of the coronary CT angio, and it is unproven in terms of predicting value in patients with stable ischemic heart disease, which is where it's used most frequently. Interestingly, a core lab demonstrated that it increased that is coronary FFR CT cost the trial in the advanced registry about $6.8 million. It also increased the incidence of PCI and CABG, that is, increased total revascularizations by 14%. And the estimated cost for the additional revascularizations were $16.5 million. So therefore, adding the cost of the FFR CT of nearly $7 million to the $16.5 million increased the cost of care to these patients by almost $23 million. So the question is, does FFR CT really get us to goal? I'm going to hold my opinion on that. Just some data that helps, that CMR helps distinguish multivessel from microvascular disease and reducing costs while increasing efficacy. A strategy of using cardiac MRI stress testing before going to catheterization versus catheterization itself was effective across all countries here, Germany, the UK, Switzerland, and the US, in inpatients and outpatients in terms of any strategy followed for detection of suspected coronary artery disease. And interestingly, a stress CMR prior to cath saved one hospital $14,000, nearly $15,000 of hospital costs per life year. $15,000 per year. And these lower costs at follow-up, which is about 1 year follow-up in these patients, suggested sustained cost effectiveness of the CMR guided strategy. So now, in terms of other value that imaging can give us with regard to differences in gender, and interestingly, across ethnicities, the MESA trial has been a way to mine that type of data from a group of asymptomatic patients. And interestingly, we've seen differences in men and women in terms of right ventricular function, as well as a number of other parameters that the MESA trial has used. I also want to mention cardio-oncology and imaging. The use of echo and particularly strain has helped us better understand the effects of non-ischemic myopathies and chemo-induced myopathies in patients and help detect subclinical abnormalities before they become important drops in ejection fraction. So either 2D or 3D strain can be helpful, and also CMR provides utility in cardio-oncology with respect to identifying myocarditis and myocardial edema, tagging for strain, and also parameters looking at diffuse fibrosis or focal fibrosis. Dr. Shara Crosby has been very active in looking at the cardiac effects of CAR T cell therapy. That is the new chimeric antigen T cell receptor therapies, which are the breakthrough therapies for oncology now and are being used across many different diseases. We'll see more data about this, but in some preliminary data, there have been cardiac events in patients with T cell therapy, just like there have been with therapy for breast CA. So we really need to be cognizant of cardiac effects of chemotherapeutic agents and cellular and molecular therapies, and particularly gene therapies down the road as we treat disease in patients. I promised you this slide of the young woman who had progressive scar when I presented verbally yesterday. Here's the data. If we look at the top image, this is a subacute study, a patient about 1 week after presentation with chest pain and positive troponins and acute myocarditis. But we can see that 2 months later, 15 months later with symptoms, she had progressive scar, that is the bright signal within the apex septum and lateral wall of the myocardium. And this occurred in the setting of normal ejection fraction. So she still had a normal ejection fraction, but progressive scarring in these areas. At 2 years later, after her initial presentation, she developed frequent non-sustained VTs, had 2 episodes of syncope, but still with a normal EF, and on EPS had an easily inducible monomorphic and polymorphic VT. A conference was held among those subspecialists. She did not meet requirements for a ICD by low ejection fraction, but it was implanted based on risk, and within 2 months, she had multiple shocks for VT at a heart rate of 250 beats per minute. That was life-saving. So risk stratification with SCAR, particularly in women, for ICD therapies and potential risk stratification for arrhythmias is on the horizon. Great. I don't have time to talk about the use of PET and MR as combined image or fusion imaging, but obviously detecting inflammation and then looking for structural abnormalities can be helpful, particularly as we try to diagnose sarcoid more accurately and more consistently. So finally, I'd just like to say, and thank you for your patience, that women's heart disease is much different than men's. Listen to women more deeply. They're trying to tell you something vital, and they're much more complex than men, as we know. Non-obstructive CAD is fatal. Be sure to diagnose it, and CCTA may be our way to do that. And prognostic data for microvascular disease with PET is real and has an impact, and therefore is vital to exclude. And then echo strain and CMR strain as well will have an impact on understanding of cardiomyopathies, all types of cardiomyopathies. And this deep phenotyping of looking for early evidence of missed ischemic heart disease is critical for female diabetic patients, and we must be aware of those abnormalities. I'll also mention that the ischemia trial, recent ischemia trial, which evaluated patients with moderate to severe ischemia, conservative versus invasive therapies, had a sub-analysis. This is the most talked about trial that doesn't have a paper out yet, so we can't drill down further into the data, but there was reportedly no difference between men and women with moderate to severe ischemia in terms of outcomes, conservative versus invasive therapies. We'll need to see that data to really believe it, but just as a foreshadowing for what's to come. Thank you again.